But I can't see.
You can't see?
No?
Yes.
Yes.
Okay, now I can also see. No problem, right? Okay?
Yes, ma'am.
Salutes.
Oh,
Yeah.
okay. I'll stop again.
Don't forget the picture that you showed to us during the guidelines, remember?
Which was that?
I think instead of dipstick,
Oh,
there
yeah,
is
I
a
have that.
special way of doing
The heat test. Heat test.
heat. Yeah,
I
I
think we
still.
lucky to have two IPNA counselors with us today. So both of you have been the IPNA counselors, right?
Yeah,
Are
you're
you
right.
still, are you still counselor, Khalid?
No, no, no.
Not.
I left, but with maybe working with couple of committees there in
Okay.
Ibna.
Okay.
But my turn is finished.
Okay.
Should I call up Dr. Dinesh is there? Dr. Dinesh, Dr. Ajay?
Should I call Dr. Dinesh?
Yes, sir. I think.
I just make a call, right?
Hi, Indira. How are you?
Hello. Yeah. Hi. Good morning to everybody. Yeah. Just got back from Ahmedabad last night. So
Right.
had a lazy
Good
morning.
morning, Dinesh. आप join कर दो. हाँ.
Yeah.
Okay. He's just joining, right?
So we are just waiting for them and then we'll start because last time it was little, we were overshooting the time. So this time we have decided that we'll stick to the time because we have a lot of questions in the chat, in the question and answer. So all those participants who have joined, please put your questions in the question Q&A box, not in the chat box.
So Neha, I was going to go a little slowly so that that it is very easily understandable. But if you are nearing the end of the 30 minutes, just give me a warning about 2 minutes previously, and then I'll wind up a little faster.
Morning.
Good morning, everyone.
Morning,
Good
sir.
morning,
Good
Dinesh.
morning.
Good morning. Sorry, I am just delayed 2 minutes. I'm busy in some advanced and RB course also. Just starting. Let me start it. I think it's 9:04.
5.
Shall we start?
Yes, sir.
Dr. Ajay is here. Dr. Ajay, sir. Dr. Ajay, sir is not joined.
Yes.
Okay.
So then you can introduce Dr. Lalit, sir.
Yes. Just one second. Yes. So, good morning, everyone. And on the behalf of IIP Delhi office, I welcome you in the second eNephro master classes session. And today's session is on approach to proteinuria. And we all know how much this proteinuria is important in our daily practice. And last class, the routine kidney investigations and proteinuria is one of the most important findings in our investigations. So there are many causes, the pathological and non-pathological also causes for the proteinuria. And today, ma'am will briefly explain the whole approach to the proteinuria along with the nephrotic syndrome also. Now, this is a wonderful session planned by the Dr. Neha Bhandari ma'am, and I must congratulate to her for this wonderful implementation also. So I would like to invite Dr. Neha Bhandari ma'am to introduce the speaker of today and the chairpersons of today. Hand over to Dr. Neha ma'am.
Thank you, sir. First of all, thank you, IIP Delhi, Dr. Dinesh, Dr. Ajay is not able to join with us today. And this sessions, I'm expecting it to be a wonderful session as last session was. And all the delegates are really excited to learn proteinuria. And first of all, I would like to welcome our chairperson, Dr. Lalit Mendiratta. Sir is a very, very renowned uh, pediatrician, and he is also a big name in neonatology. I know he's very keen in pediatrics and neonatology. Welcome, sir.
Thank
Then
you.
I would like to introduce our expert, Dr. Khalid Al Hassan. So, sir is a very renowned pediatric nephrologist and researcher from Saudi Arabia. He's professor of pediatrics as well as a renal physician, and he's currently also president of Saudi Society of Nephrology and Transplant. He is also the counselor for IPNA, which is International Pediatric Nephrology Association. There are so many papers written by him. He has almost 160 plus peer-reviewed publications. Welcome, sir. I am sure we will be really enlightened with your knowledge in today's session. Then I would like to introduce our speaker. So, madam does not need any introduction. Dr. SUSHMITA Banerjee. So, madam is a consultant in Department of Pediatrics, Calcutta Medical Research Institute. She has been Associate Editor of Pediatric Nephrology Journal, member and Senior Advisory Council of ISPN. So, madam is one of the persons who makes guidelines for all these nephrotics as well as a lot of other pediatric nephrology subjects. So, welcome, ma'am, and we'll not waste too much time. Over to you.
Thank you, Neha, and a very big thank you to IIP Delhi for inviting me to participate in this webinar series. I'll just share my slides first. And I hope it is visible.
Yes, yes.
You can see the slides in slide share mode. Okay. So thank you once again. And as has already been mentioned by the chairperson, proteinuria is a very common finding when we check the urine for a normal urine analysis. So over the next half an hour, the objectives of my talk would be to try and understand what constitutes proteinuria, to differentiate between benign and pathological etiologies, and thereby to decide which patients require further follow-up and evaluation, so that we do not really investigate patients who have physiological proteinuria, but we investigate thoroughly patients who have pathological etiologies so that we can treat them efficiently and properly. We also want to identify the cause in a very systematic manner and recognize the need for referral to a specialist, be it a pediatric nephrologist or be it pediatric surgeon or whoever. So before we go on to our cases, I would like to discuss a little bit of the background. Why do we not have proteinuria in the normal state? The reason is that there is a glomerular filtration barrier between the blood in the glomeruli and the urinary space. And this barrier, it has several small spores on the endothelial side. These spores are so small and they are negatively charged. Because of this, bigger molecules like albumin, as well as red blood cells and other proteins are not allowed to pass into the urinary filtrate. Because of the negative charge of these spores and the negative charge of protein molecules, there is also a repulsion of the protein molecules from passing through these pores. And these two, in effect, prevent proteinuria in the normal state. Despite this, a small amount of protein does pass through these pores, but it is such a small amount that it is all reabsorbed in the proximal convoluted tubule. And therefore, when we test the urine normally, we would normally get about proteinuria of about negative or trace on a dipstick. A little bit of tubular protein is secreted in the normal state. However, this is a benign phenomenon, and most of this is TAM phosphoprotein, and it does not have any clinical significance. So what are the definitions of proteinuria? The normal range of protein excretion in urine is less than 4 milligram per meter squared per hour in a timed urine collection, or less than 100 milligram per meter squared per day if we do a 24-hour urine collection. If we do a spot urine protein creatinine ratio, then it is less than 0.2 milligram per milligram of creatinine. And all these values are slightly higher in infants less than 6 months to 1 year. So then what is pathological proteinuria? So anything above these values is pathological. Nephrotic range proteinuria is a very big amount of protein in the urine, which is defined as more than or equal to 40 milligram per meter squared per hour, or more than 2 milligram per milligram in a spot protein creatinine ratio. And anything between these two values, that means 4 to 40 milligram per meter squared per hour, or 0.2 to 2 milligram per milligram for a protein creatinine ratio, is termed as non-nephrotic range proteinuria. What may be the sources of proteinuria when it occurs? Proteinuria may be glomerular, and glomerular proteinuria is usually of greater quantity. Glomerular proteinuria can be selective when the damage is small, and so it allows smaller molecular weight proteins like albumin to pass through. Or glomerular proteinuria may be non-selective when there is very significant high amount of damage, so that larger protein molecules also pass through. So the selectivity of glomerular proteinuria gives us an indication of how severe the glomerular damage is. Then we might get overflow proteinuria, which occurs in hemoglobinuria or myoglobinuria, where there is so much of this protein produced and secreted into the blood that some of it passes through into the urine. And then finally, we have tubular proteinuria, which is usually of much lower quantity. And this may occur due to damage, which may be congenital or acquired, of the renal tubular cells, so that there is a lack of reabsorption of the low molecular weight proteins, example, beta-2 microglobulin or retinal binding protein. But other than this, there might be tubular secretion of proteins in tubular injury. And these are new protein biomarkers like NGAL, which are nowadays, you will find many studies looking at these biomarkers in different types of renal tubular injury. Next, how do we measure urinary protein? The most common bedside test is the semi-quantitative test by dipstick, where the results, according to the color change, range from negative to 4+, and this gives us a rough idea about the amount of proteinuria. However, this is only a rough idea because there are many false negative and false positive reports. False negative report is possible when the urine is very dilute or acidic, or if there are non-albumin proteins present in the urine. False positive reports occurred if the stick has been immersed for too long, contamination with different substances, or if the urine is very concentrated. And then the other method, the very old method that we used a lot in our training period when dipsticks were not so freely available, is the boiling method, plus minus the sulfur salicylic acid addition method, where by boiling the protein becomes turbid, and you get, according to the degree of turbidity, a rough estimation of the amount of proteinuria can be made. While the advantage of this is that it measures all proteins and not just albumin like the dipstick method, however, it is a cumbersome method and quite rarely performed nowadays. If we find a urine protein positive by dipstick, the next step is usually to quantify, to see how much the urinary protein amount is. And as we discussed in the last slide, the dipstick can have false negative or false positive reports according to urinary dilution. However, this dilution effect is overcome if we look at urinary protein creatinine ratios. However, the gold standard is the timed urine sample, and the 24-hour urine sample is what we actually look at as gold standard in older kids. However, in younger kids, it's very difficult to collect a 24-hour urine sample. And therefore, in such patients, younger children where 24-hour samples are not possible, urinary protein creatinine ratios are adequate, as many studies have shown that they have good correlation with the timed urinary values. Now coming to proteinuria types, you can have proteinuria which is benign, physiological, or transient, and you can have proteinuria which is persistent and which needs more detailed evaluation and follow-up. So the physiological proteinurias, which are Thought to be benign are orthostatic proteinuria, where proteinuria occurs in an upright position, usually seen in older children. And we exclude this by looking at a urine protein in a sample just after the child has woken up after a overnight sleep. This is thought to be benign, but does need follow-up and no further evaluation if the early morning urine protein is normal. Similarly, we have a condition called exercise-induced proteinuria, where protein comes into urine after heavy exercise. And again, if we look at urine, we repeat a urine after, say, a 2-day restful period, this urine should be normal if it is exercise-induced. And again, it is considered a benign condition and requires follow-up, but not detailed evaluation. Then we have transient proteinuria, which occurs in acute diseases such as dehydration, urinary tract infection, AKI, febrile illness. And in transient proteinuria, if we repeat the urine once this acute illness has resolved, then we should find that the proteinuria itself has resolved as well. Then we come to persistent proteinuria, which may be isolated. So there are no other symptoms, just proteinuria, which is picked up incidentally. Or persistent proteinuria may be symptomatic, associated with many other symptoms, as we will see in our cases. Isolated proteinuria, how do we know that it is not something like orthostatic or exercise-induced or transient proteinuria? Well, we have to recheck the urine protein up to 3 times over a period of 4 weeks to confirm persistence. And persistent proteinuria, which is present even in an early morning sample, we have to take seriously and we have to evaluate thoroughly. Okay, so then we come to our first patient, patient SP, a very characteristic presentation, a 2-year-old male who has progressive edema starting after a cold. The child has reduced number of times, reduced urine frequency. There is no macroscopic hematuria which the parents complain of. Blood pressure in clinic is normal for his age, and a dipstick in clinic shows urine protein of 3+. So I think you will agree that this is a very typical presentation. And when we see patients with proteinuria, with symptoms associated with proteinuria, we should try to see which presentation group the child fits into. So these presentation groups can be mainly patients with mainly nephrotic features, patients with an association of nephritic or nephrotic features, patients with suggestion of tubular disorders, or patients with suggestion of urological disorders. So let us see in brief what these different presentations could involve. Nephrotic features are usually oliguria and edema, and no nephritic features, which we will go into next. So these nephrotic features on its own are usually seen in childhood nephrotic syndrome, which if it responds to steroids is usually due to minimal change disease. And in steroid-resistant or difficult nephrotic syndrome cases, there may be underlying FSGS or membranous glomerulonephritis. And these patients we confirm by looking at creatinine, albumin, cholesterol, and only in steroid-resistant or very difficult nephrotic syndrome patients do we require further investigations such as renal biopsy or genetics. Now coming to the nephritic or nephrotic presentation, in these children, along with a lower grade of proteinuria, we would find oliguria, hematuria, fluid overload, hypertension, and sometimes systemic manifestations like rash, arthritis, pulmonary, and neurological involvement. The prototype of a nephritic syndrome is usually post-streptococcal glomerulonephritis, but it can be more serious diseases like rapidly progressive glomerulonephritis. Patients with IgA nephritis, membranoproliferative nephritis, C3GN, hemolytic uremic syndrome, different vasculitides can present with nephritic or nephrotic features. And in these symptoms, when patients present with such symptoms, we need to do a more extensive evaluation, including, of course, creatinine, but also hemogram, a blood smear, LDH to exclude HUS, ASO titers, C3, C4, ANA, ANCA to look at the different glomerular nephritis, IgA levels sometimes, and ultimately in the more difficult patients, we need to do a renal biopsy to further evaluate what the renal histopathology is. Tubular disorders are suspected when there is polyuria, polydipsia, short stature, acidosis, alkalosis, rickets, etc. And these occur in tubular conditions like Fanconi syndrome, Benn disease, cystinosis, etc. But tubular proteinuria, as I mentioned previously, due to tubular interstitial damage, can also occur in conditions like obstructive uropathies, acute tubular necrosis, etc. And these features warrant looking at blood gas, serum and urine electrolytes, calcium, phosphate, amino acids in the urine. And when we are suspecting tubular diseases, we would also look at beta-2 microglobulin. Tubular injury, we would look for NGAL, and many of these tubular disorders will require genetic studies for confirmation. And lastly, urological disorders usually have a completely different presentation with presence of dysuria, maybe fever in urinary tract infections, along with loin or suprapubic pain. And in obstructive uropathies, we might find an abdominal lump. And these features occur in UTI, stones, polycystic kidneys, obstructive uropathies, tumors, and require urine cultures, renal function test, renal imaging for thorough diagnosis. So when we come back to our patient, you have already seen that the child has just edema and oliguria, no hypertension, no hematuria, no other systemic involvement. We proceed to do further tests on this child. Other than 3+ of protein, there is no hematuria, but there are granular casts. We do an early morning urine protein creatinine ratio, which shows nephrotic range urinary protein. The serum creatinine is normal for age, and the serum albumin is low. So this child actually presents with a very typical nephrotic presentation. And this is in our patients with this typical nephrotic presentation without any complications, we would usually give a trial of steroids. This patient is started on the standard steroid dose as per our protocol, and he fortunately has a steroid response. His edema subsides and his proteinuria resolves. So he has steroid responsive proteinuria, and we proceed to treat him along the lines of our protocol. This child subsequently develops steroid-dependent nephrotic syndrome, requires several steroid-sparing agents, and has a later kidney biopsy after having been on tacrolimus for 2 years, which shows minimal change nephrotic syndrome. So we have seen a patient with a classical nephrotic syndrome, which is really the most typical presentation in the pediatric age group. But we can also get patients with nephritic or nephritic nephrotic presentations, and these are some patients that we have seen over the years. So classically, these patients have hematuria, hypertension, different degrees of acute kidney injury. And as I mentioned, the prototype is post-streptococcal glomerulonephritis. You can also get this kind of a nephritic presentation along with henoch-Schondlein purpura nephritis. Almost 30 to 50% of patients with HSP will have some degree of nephritis, mostly presenting in the first 6 months. So it is protocol that in the first 6 months, all patients presenting with HSP rash should have urinary screening at least every 2 weeks to 4 weeks, up to 6 months of presentation. This is a patient with Kawasaki disease, and in Kawasaki also we can have hematuria and proteinuria, which usually resolves once the other symptoms of the Kawasaki disease has been treated and has resolved. So this is usually a transient proteinuria. And then you have more rarer cases. This is a child with polyarteritis nodosa. This is a child which is with vasculitis, what used to be called Wegener's disease, with extensive lung involvement, lung cavitations and caseation. And this is a child with SLE with a typical butterfly rash. So all these syndromes are the different vasculitides which can have very severe renal findings and which are usually diagnosed by kidney biopsy, along with different serological tests such as ANA, ANCA, etc. And this is a very rare patient who has acquired lipodystrophy. So you can see that the cheeks have become concave and the calf muscles look hypertrophied. This patient had underlying membranoproliferative glomerulonephritis, which is nowadays called C3GL. So once we suspect that there is a nephrotic component, further serological tests and most often further renal biopsy, except for the very straightforward patient with post-streptococcal glomerulonephritis, is usually the norm. Tubular or tubular interstitial diseases can also present with proteinuria. And again, these are some conditions we have seen where there was proteinuria along with many other symptoms and signs of a tubular disease. So this is the cystine crystals in the eye in cystinosis. This is a patient with Fanconi-Bickel syndrome with Fanconi syndrome of the kidneys. And this is a child with severe nephrocalcinosis, which occurred in dense disease, who also had very high levels of proteinuria. And then you can also find proteinuria in patients with severe tubular interstitial involvement due to obstructive kidney disease, due to vascular-ureteric reflux, as in this patient who had severe reflux nephropathy bilaterally. So we have looked at patients with symptomatic proteinuria. Let's now look at a patient who had asymptomatic proteinuria. So this is a 14-year-old male child who himself, because he was a little older child, could complain of noting frothy urine for almost 4 months before he came to us. There was no other symptoms at all. His blood pressure was normal and urine analysis showed microscopic hematuria as well as proteinuria. So the first step was to look at his first morning urine protein creatinine ratio, which was again very high, again in the nephrotic range. His creatinine was 0.8, which as per his height gave a eGFR of 84, which is slightly suboptimal, normal being 90 and above. So how do we approach a child with asymptomatic proteinuria, which is usually picked up incidentally? First of all, we look at the first morning urine for protein, and looking at the first morning urine, that usually excludes orthostatic and exercise-induced proteinuria. So if proteinuria is persisting in the first morning urine, we confirm by a quantitative test. This child was a 14-year-old child, so we could have done a 24-hour or a timed urinary protein excretion, or in a smaller child, we can do a spot urinary protein creatinine ratio in a morning sample to confirm the degree of proteinuria. Next, if there is again a confirmation of proteinuria by a quantitative test, we need to confirm persistence. That is, in an asymptomatic child, that is, we need to confirm that it persists at least 3 times over a period of 4 weeks. Now, in persistent proteinuria, as we have mentioned several times, a very thorough evaluation is required. So we need to look at family history carefully because conditions like Alport syndrome, polycystic kidney disease can present with proteinuria, familial FSGS also. We need to look at a fresh urine for microscopy to look for hematuria, to look for casts. We need to do the full gamut of renal biochemistry and serology to look for subtle markers of glomerulonephritis and for other inherited and other diseases. We need to look at eyes and hearing, and this is mainly looking towards Alport syndrome. We also need a renal imaging, a basic ultrasound to look at renal size, echogenicity, structural abnormalities, etc. And further imaging may be required depending on what we find in the initial finding, in the initial evaluation. So if abnormalities on this screen are detected, according to what abnormality we find, further detailed evaluation is indicated. What happens if we just continue with isolated asymptomatic proteinuria and this whole evaluation is normal, which is what occurred in this current patient? So if it is very mild, the degree of proteinuria, it may be monitored to see if the trend is persistent or rising. But in our patient, he had already had 4 months of proteinuria, and it was a very significant amount of proteinuria. So in such a patient, a renal biopsy and or genetic tests are indicated. So biopsy will diagnose conditions like as Alport's disease, FSGS, etc. And genetic tests will also confirm many conditions like Alport's, DENS, etc. Let us just look at this nice study performed in Tamil Nadu in 2021. It was a school screening analysis of asymptomatic children and included almost 2,000 children. And you can see that on the first analysis, isolated proteinuria occurred in quite a large, almost 10% of children. However, when these children were followed up over 4 weeks, there was persistent proteinuria in only about 1.3%. So a single check in asymptomatic proteinuria is not adequate. Many of these patients on follow-up will not have proteinuria, but the few that do will need further evaluation. What happened in our patient? So we have shown that he had microscopic hematuria. He had nephrotic range proteinuria on quantification and a slightly high creatinine with a lowish eGFR. There was no family history. We also checked the parental urines, which were normal. There were no extrarenal manifestations. We checked his eyes and his hearing, which were all normal. And we did a thorough, extensive serological tests, which were all normal. So then we went forward to do a kidney biopsy. And our biopsy showed that this child had IgA nephropathy, which you can see with IgA lighting up in all the mesangial areas in this immunofluorescence study on the biopsy. And there was mesangial proliferation, endothelial proliferation, and there was also a cast. So IgA nephropathy the histopathology is described by the MES-seq classification, which not only confirms that IgA nephropathy is present, but also the degree and the severity of involvement. And because there was a cast, there was a significant amount of proliferation of mesangial and endothelial cells. This child was treated with intravenous pulse methylprednisolone along with RAS inhibitors, which were then changed after the first 5 doses of IV methylprednisolone to oral steroids and MMF as a steroid sparing agent. After 1 year, his urine PCR had come down significantly, as had his creatinine, and you can see that his eGFR has gone up now significantly. And over time, he continues on RAS inhibitors with further reduction of his PCR value. So let us move on now. I wanted to say a few words about albuminuria, because if you look at adult studies and if you look at adult patients, you will find that the adult nephrologists look at albuminuria or ACRs much more commonly than proteinuria. So why do they do that? So albumin, of course, is part of the whole amount of protein that is being excreted in the urine in a pathological state. But assays are more sensitive in picking up very low levels of urine albumin. So the low detection level for albumin is 0.3 milligram per deciliter compared to the lowest detection level of protein, which is 4 milligram per deciliter. So we can pick up albumin excretion much earlier. And because of this, the albumin-creatinine ratio is most commonly used in adults as a very early marker of subtle renal injury, such as in diabetic or hypertensive nephropathy. And in all ages, even in pediatrics, the ACR is used to categorize CKD. And you may have all seen this chart which shows that with increasing albuminuria, so ACR increasing from 30 milligram per gram to 300, there is an increased risk of progression of CKD, along with deteriorating GFRs. So that is why ACR is important. But for us, other than for categorization of CKD, mostly PCR is used as per all our standard protocols and guidelines, not only for diagnosis, but also for prognosis and for monitoring patients with pathological proteinuria. Lastly, a few words about proteinuria management. Proteinuria, as we have seen, is a marker of kidney inflammation and damage. But apart from that, progressive or persistent proteinuria is also a driver of CKD progression. So we may treat the disease, but if proteinuria persists, proteinuria per se will be a risk factor for CKD progression. And these are very large adult studies with thousands of patients which show that greater degrees of proteinuria are associated with greater GFR decline. So what we want to do is we want to give specific treatment for the disease so that the proteinuria as well as the disease causing it is cured. But in several conditions, such as in chronic renal diseases like IgA nephropathy, Alport syndrome, some steroid-resistant nephrotic syndromes, we cannot cure the underlying disease. In these cases, we need to provide non-specific treatment of proteinuria to try and improve the odds of developing or to try and reduce the odds of developing CKD progression. Reduction of proteinuria in several long-term studies. This is a registry of steroid-resistant nephrotic syndrome. This is IgA nephropathy. In both these long-term studies, you will see that if we can reduce proteinuria, patients in remission, the kidney survival is much better than in patients where proteinuria is persistent. So all our standard guidelines, ISPN, the IPNA, KDIGO, all our standard guidelines suggest that we should aim for the maximum possible proteinuria reduction, and the drugs available to do this to us are the renin-angiotensin-aldosterone system inhibitors, which are the angiotensin converting enzyme inhibitors, ACE inhibitors, or the ARBs, the angiotensin receptor blockers, which by reducing intraglomerular pressure, by reducing fibrosis in the interstitium, have a renal protective effect. What is important for pediatricians to know is that you might find a patient with a renal disease, with a chronic renal disease, on one of these drugs, an ACE inhibitor or a ARB. But if this child has got an acute illness which causes intravascular volume depletion with vomiting, diarrhea, poor intake, or if this child has an AKI, then these drugs need to be stopped temporarily and can be restarted when these acute conditions are overcome. Now, RAS inhibitors for proteinuria. Experience with these drugs over the years has shown that the reduction in proteinuria is very variable in different patients. And if initially you have a very significant fall in proteinuria, but with months of therapy, this effect actually reduces so that the proteinuria level rises again. So RAS inhibitors are not really providing the optimum possible renoprotection, although they are providing some renoprotection, but can be improved this proteinuria reduction with other agents. Now in adults, several agents are now in use. They are in many trials, and some of them have already come into regular use. And these agents are the SGLT2 inhibitors, empagliflozin, dapagliflozin, you may have heard of, the non-steroidal mineral corticoid receptor antagonists such as finerenone, the GLP-1 receptor agonists. You have heard of these drugs when they are used for obesity. and the dual endothelin receptor antagonists like sparsentan and combinations of all these therapies. So many of these agents are already recommended in diabetic kidney diseases, and SGLT2 inhibitors are also recommended in CKD with proteinuria in adults. However, in children, these drugs are yet to come into the guidelines, and we await the outcomes of a few trials that are underway utilizing these agents. However, you can see that in comparison with adult trials, we have very few trials going on in children. And so there is really a big lack of data in children and a significant gap and a long lag period for these agents to come into practice. And we look forward with optimism to these agents being proven to be of use in children, because hopefully they can add on to the renoprotective action of the ACE inhibitors and the ARBs. So coming to the messages that I would like to leave you all with, proteinuria may be a physiological feature. As we have seen, it may be benign, in which cases we just need to follow up, or it may be a feature of many different renal and systemic diseases which need evaluation and management. So we have to differentiate benign forms from pathological entities. We do not want to over-investigate the benign forms, but we don't want to leave the pathological entities uninvestigated or untreated. Symptomatic and persistent forms require detailed evaluation and treatment, and this is where the teamwork between pediatricians, pediatric nephrologists, pediatric surgeons, geneticists, pathologists come in. So with good teamwork, we should be able to find the cause and to treat it effectively. Other than being a marker of injury, proteinuria is also a poor prognostic factor for kidney survival. So proteinuria in itself can cause progression of CKD. And in such patients, non-specific anti-proteinuric treatment, in addition to specific therapy where available, will improve the outcome. And here are some articles for further reading. And in the end, this cartoon is to try and show that together we can improve the outcome of most kidney diseases. Thank you.
Thank you, ma'am, for the wonderful session. We would like to have a few words from an expert, Dr. Khalid.
Yeah, thank you very much. And thank you, SUSHMITA, for really wonderful, enlightening about the basic and the more advanced in the management of proteinuria and and also the cause of proteinuria, and which completely do agree about it. And classically, the orthostatic, I saw some question about orthostatic proteinuria. We could see it with athletics, especially athletic females. You can see the orthostatic proteinuria. And of course, of all of this, the most common cause, as we are a pediatrician, that we see is the nephrotic syndrome. That's the most common cause as a pathological cause of the proteinuria. And most of the time, they are fortunately steroid sensitive. They do respond to the steroid and without any progression to renal disease. So in addition all what have been said, probably the one comment that the commonest pathological cause in kids is the nephrotic syndrome, and fortunately in kids usually it is steroid sensitive. And probably one comment about on the advanced treatment, and SUSHMITA, she enlightening us very nicely about the new meds that's been used. Probably the SGLT2 have been actually used now extensively, even in adolescents between 12 years to 18 years, and have been approved by a couple of agents like FDA and our also Saudi FDA is approved for use for above 12 years, 12 to 18 years. In couple of cases, the classical example as mentioned is the Alport syndrome. And the nice of it, its side effect is very minimal. The only thing we need to look at that it can precipitate urinary tract infection, especially if have been used in patients with immune suppression like kidney transplantation. So that's my comments on this.
Dr. Neha, I can make a comment. Very nice presentation. Am I audible?
Yes, yes.
Dr. SUSHMITA, very nice presentation. We as a clinician, general pediatrician, we are always get the patients of proteinuria, right? So
Right.
many times, I've got just two things to ask. Sometimes it is tubular, sometimes it's glomerular. Glomerular, you will come to know it is in the nephrotic range. What about the tubulars? We don't want to miss those tubular proteinurias. So now, how can you distinguish? You said this dipstick is only for albumin only. It's not sensitive. So means we should get a electrophoresis done, or what should we do? We should not miss the
So,
tubular proteinuria because many patients we will be missing. And secondly, this one of your patient had so much of renal protein loss, but he did not have edema. That's the second thing. And the last thing I want to know, what is the commonest cause of persistent proteinuria in asymptomatic in India, means in childhood? Which is the commonest pathology you get?
so your first question was, I think, I'm sorry,
Tubular
tubular.
proteinuria.
Okay, so I think tubular proteinuria shows up if you look at urinary PCR, it will show up. Okay, but it won't show up on dipstick. The tubular proteinuria is usually of a very small amount when you look at overall quantity, and you have to really suspect tubular proteinuria. And you would really suspect it if there are other manifestations which I have
Correct.
showed in that table briefly, such as poor growth, such as family consanguinity, family history of consanguinity, other electrolyte abnormalities, rickets. Those are the conditions where you would really suspect that that there might be tubular proteinuria. Dense disease is one disease where the proteinuria, although it is a tubular proteinuria, it can be very extensive. So your normal urinary protein sticks might even show amount of protein, even though most of it may not be albumin, but there is even sufficient albumin there to show up on dipstick, dense disease. But most of the other tubular diseases, you would have to really suspect it and then look for the tubular proteins in particular, the lower molecular weight proteins. But there are many other symptoms and signs which would indicate it. The question about some patients who have nephrotic range proteinuria but do not have edema, the reason is because in these patients, the serum albumin is still maintained. And I don't know if anyone knows the cause of these patients. We always find some patients with FSGS, some patients with Alports, even IgA nephropathy, as this patient showed, where the protein, urinary protein levels are very high, but yet probably because of compensation processes from the liver, which is making enough albumin, there is no hypoalbuminemia, and therefore there is no proteinuria. And final, there was one question.
What is the commonest pathology you get in persistent proteinuria in childhood?
It could be anything. I think the numbers are so small that it is difficult to say which is one cause. But I have seen it in Alports, in steroid resistant, in familial FSGS, we have seen it. I have seen it in a child with a PAX2 mutation in the family. So this kind of, it can be very variable, but because the numbers are small, when you look at persistent proteinuria, if you look at the one urine analysis showing proteinuria, it is quite a large number. But when you look at persistent proteinuria at 4 weeks, the numbers are small. So it's difficult to tell you one definite problem that is commoner than all the rest. But a smattering of all these diseases, I think all of us have seen. Dr. Khalid, or Dr. Vasudev, any comments about that?
I totally agree with you. And the only thing that I can say that and reassure my colleague that tubular proteinuria, it's not the symptoms or the sign that will bring your attentions. So your attention, it will be brought up by other things, like for example indents. You will see stones in the kidney, nephrocalcinosis, and in other you're gonna see as exactly what you mentioned, the extrarenal manifestation, like for example general failure to thrive, photophobia like in cystinosis, hepatosplenomegaly. So tubular proteinuria, it's not the first thing. You during your investigation you will notice that you have a tubular proteinuria, but definitely other thing will comes to you other than tubular proteinuria.
Dr. Lalit, as you were saying, some of these children do have proteinuria, but they do not have edema. This mostly we find in children who are older children, well built, and you may detect, like if they are nephrotic, they have cough, cold, and other illnesses,
But
and you
edema is
find
not.
some proteinuria, but edema will take time to, and the younger children will have edema very fast. What we have seen in older children, the edema comes late once they have had proteinuria for quite some time. But if you detect early, sometimes the albumin level has not yet fallen, and you may not find frank edema to be present, while you see on dipstick the proteinuria is present. So
Yeah,
that's why we always tell the parents that you, during the illness, be very careful and be very cautious and alert, and keep doing your dipstick test every day during illness so that we can detect the proteinuria early. And if it is persisting, then we take an action on treatment also.
Right. And one more thing, do we find post-streptococcal glomerulonephritis nowadays, because rheumatic fever is also gone? Do you see this nephrologist people, do you see those people, these patients of post-streptococcal nowadays? I have hardly seen for so many years.
We still see. Yeah, we
Still,
are seeing patients, yes.
or incidents have
Maybe
fallen down.
the incidence has definitely fallen, but we are still seeing patients, yes.
I think it depends on the type of clientele you are seeing. What
Yes,
you are
yes.
seeing is probably all elite and well-off people. But if you come to general hospitals, and so hematuria is still the commonest cause in our country, is still acute glomerulonephritis, I would say. And in smaller centers, in peripheries, or in government hospitals, you still see these cases coming up.
And still it is post-streptococcal maximum.
Post-streptococcal
I,
is the
th-
commonest.
I probably my colleague will agree with me. We do prefer to name it as post-infectious GN rather than post-stripped, because anything can cause it. Any bugs, including viruses, can cause the same thing now.
Absolutely.
Ma'am,
Dr. Siddharth, one of our colleagues who's a pediatric nephrologist in Gurgaon, he's also saying that we also see enough patients. And
So, right.
probably, Dr. Lalit, your clientele is one which do not
I have to be careful. I should not be missing it, bro.
Yeah.
so ma'am, there's question for you. Mostly the nephrotic patients in age group 2 to 6 years, but if presenting for the first time at around 10 to 14 years, that too a single episode, no further episodes, what does this signify, and till how much time should we keep them in follow-up?
We do get a few patients who present late and have a good outcome, but we have to be really aware that in many patients that present late, there may be a non-minimal change pathology. So I think we would keep them under follow-up for at least 2 years, but then we would also inform them that if there are any concerns of edema, etc., and to keep checking the urine protein, especially during acute illnesses, and to seek medical review if there is a recurrence of proteinuria. Some of these patients I have seen, if they have got better the first time around, sometimes they can have a very insidious amount of proteinuria over the years, which, if not monitored for and not picked up, can be representative of an underlying FSGS. So it is very important really to follow up these patients to make sure that the proteinuria is truly resolved and has not recurred or persisted.
And he wants to know, Dr. Dushyant wants to know, is there any promising blood markers to predict relapse in frequently relapsing nephrotic syndrome? We still are searching.
I think the easiest is why do you want a blood marker? The easiest is the urine protein dipstick. So just ask the patients to do a dipstick, maintain a nephrotic diary, and come for review as soon as it shows 2+ or more for more than 3 days. It's really the easiest thing to do. Particularly when the child has a cough or cold or any other intercurrent illness, that is the time, even if they are not monitoring daily, when they have been in remission, say for 6 months, 1 year, they may get out of the habit of monitoring daily. But at least during the infectious intercurrent illnesses, that is the period then that they must monitor and look out for a relapse.
For early morning urine protein creatinine samples has to be run in how much time? So basically this has to be, you can put the urine protein sample till 3 days also, but for creatinine it's stable only. So I think you can send it to another place also if not available in your hospital. Ma'am, what's your take on that?
Yes, absolutely. Many of our patients live very far from our center. So they come with the early morning urine protein and they may be traveling 4 or 5 hours. So, there is no problem with, we are only careful about urine cultures, which should be, plated within 1 hour. We say should reach the lab within 1 hour when we are talking about screening for UTI with urine cultures. But urine protein and urine PCR, several hours don't make a difference.
Yeah. Probably unless the patient have significant hematuria. So if you stay a long time, the RBC get ruptures and you get more proteins in the other side. But this is in rare situation. Otherwise, I agree with you.
Correct.
Okay.
But otherwise, it's a spot test only, UPCR only. Right.
So I think we have finished with the questions. I would request
There is
Dr.
something about Neha about a nephrotic diary. Can I quickly go over that because that's probably important? So all nephrotic syndrome patients should keep a diary where they have 3 columns. First column is the date. Second column is the urine protein measured by dipstick every morning in the first or second urine sample. And the third column is the medicines. And they should really continue this every day during their active nephrotic periods for 2 to 3 years, really, and more if it's a difficult nephrotic syndrome where the disease can go on for several years and they can be treated with many different steroid-sparing agents. And it's very easy for the clinician to look at that diary and to determine how many relapses, how long the child has taken to remit, what are the steroid-sparing agents that have been used, and decisions can be made really quickly based on that. Otherwise, you're faced with a situation when you're trying to go back through the history and the parents may remember, may not remember correctly, and it becomes very difficult. So very simple nephrotic diary, 3 columns, something that should be told to the patient on the very first diagnosis of nephrotic syndrome. And the parents must be told the importance of urine monitoring and for coming for review as soon as there is a relapse, very early in the relapse. So there is no edema, no complications of the nephrotic syndrome. So all these infections, hypovolemia, AKI, all these complications of nephrotic syndrome usually occur when the relapse has been missed for several days. So that the aim is to try and treat early.
So there's one more question for you. In FRNS children precipitated by infection admitted to hospital, when to start oral steroids, roughly after how much time of antibiotic duration, fever relieved or cultures, how to decide?
If the patient has been on steroids long term, and if the patient is, so since you're saying the patient is admitted, I'm taking for granted that he is admitted with a severe complication, right? Maybe peritonitis, maybe a pneumonia or something like that. In that case, we would start antibiotics and give a stress dose steroid because we do not want an Addisonian crisis in a child who has already been on steroids for a long time. Once the child comes out of that acute phase, we can change over to a norm. And if the child is still in relapse, we can change over to the normal 2 milligram per kg oral steroids, and the child is able to take orally. Does that answer the question?
I think we have answered all the questions. So I would request Dinesh sir, please.
Yeah. Thank you,
Can I
Dr.
make
Neha.
a small comment, Dr. SUSHMITA? Wonderful talk.
Sir, we
all
are
the
lack of
pediatricians.
time actually.
Okay, but just one small thing that
Yes.
all our pediatric friends, I think very important that take a blood pressure in all these children where you come across renal problems, whether nephrotic or related proteinuria. Do not forget to take a blood pressure in the beginning. And if the child is on steroids for long term, again, take a blood pressure at least once in 3 months or so that these children may get hypertensive later also on steroids. Okay, thank you.
Thank you, sir. Thank you. Such a wonderful comment. Thank you, Dr. Neha, and such a wonderful execution of this session, and very nicely collected the all facts by Dr. Sushmita ma'am, and very pertaining point raised by Dr. Khalid sir and Dr. Malalit sir. Now I request our President sir to say a few words, sir. Dr. Ajay, are you here, sir? Dr. Ajay, sir? I think sir is not here. Yeah, muted. So proteinuria, you know, all is one of the main investigation in the initial AKI cases and then the nephrotic cases. And on the basis of that, we can approach the nephrotic cases and we can also follow up in these cases. Now, I would request Dr. Ravindra Kumar to say a vote of thanks for this session. Thank you. Dr. Ravindra is here. I think Dr. Ravindra has not joined. No, I must say vote of thanks. I thanks all the delegates and all panelists and mainly the speaker of today, Dr. Sushmita ma'am, and Dr. Neha Bhandari, the coordinator of the whole program, for this wonderful session. We'll meet in the next session again. Thank you so much. Good day.
Thank you. Thank you very much.
Thank you so much.
Thank you.
Bye.
Happy Sunday, everyone.
Thank you very
Bye-bye.
much. Bye. Bye-bye.